Hello, my name is Richard Channick. I'm from UCLA Medical Center in the Pulmonary Vascular Program, and it's really my pleasure to give you a little overview of some of the interesting and important abstracts that were presented at the recent CHEST 2020 meeting, which was, of course, a virtual meeting, but there were still some quite interesting findings. And so, if you don't know, the CHEST meeting is a very large meeting of the American College of Chest Physicians. Usually a live event, sadly not this year, 4-day event, and gets, well over 5,000 attendees and numerous different sessions. It's a big meeting held at large convention centers. And certainly in the pulmonary arterial hypertension world, we see developments presented really every year at the CHEST meeting that are sometimes quite impactful. So we looked through this year's meetings, and I tried to just, obviously can't get to anywhere near all the abstracts presented, but to pick out for you some of the more important, what I found more interesting ones. So let's just roll into it and we'll talk about. So this first one was physicians' attitudes towards anticoagulation use in patients with pulmonary arterial hypertension. This was a survey of 56 clinicians and asked them, would they use pulmonary arterial anticoagulation for group 1 PAH, idiopathic PAH in particular, or connective tissue, breaking it out, the forms of PAH. And in fact, they found that about a little less than half of clinicians would consider anticoagulation group 1 PAH, fewer for idiopathic PAH and connective tissue in particular. Now, you may or may not know this, but the whole anticoagulation issue in group 1 PAH is somewhat controversial, and there are data suggesting that anticoagulation doesn't really add much to survival, and a couple of things that suggest they do. So in our sort of recent guidelines, we said that sort of left it up to the clinician, but in patients with idiopathic PAH, there's probably not a lot of data to support the use of anticoagulation. But I would say that it's still an unanswered question. So this is interesting to see that, clinicians are hesitant to routinely use anticoagulation. I don't think I would argue with that sentiment. I think there are individual patients that might benefit from it. So this is sort of an interesting survey. The next relates to the psychology of pulmonary arterial hypertension. I'm not a psychologist, but I take care of a lot of patients with a very severe illness, in some cases life-threatening. And it's certainly not surprising that that kind of a situation with a chronic disease can cause a lot of psychological and emotional issues. And this study looked at 59 patients with PAH, given a questionnaire to answer about how they felt living with this disease. And there were a number of interesting findings. There was a general theme of sadness and darkness in to quote one of the questions and one of the answers. I could just read it to you. This is how I felt from the onset of diagnosis and at times since diagnosis. It hasn't always been gloomy, but there's certain times I go back to that place in dealing with this disease. Again, I think we sometimes don't appreciate how hard it is to deal with this kind of a chronic condition that's always there. But on the other hand, there were sort of hopeful sentiments offered by patients about really putting life in perspective. And again, I think this comes from having a chronic disease. Things that seem more important to patients suddenly don't. So I think as we continue to manage these patients, and I'm using the term chronic disease, and I think that's actually a good development, because when I started doing this wasn't a chronic disease. Patients died pretty quickly. So now that we have treatments, we actually have a chronic disease, but we need to deal with some of the consequences of patients living with that chronic disease and how it impacts not just them, but their families, caregivers, et cetera. So I found this pretty interesting. The other area that's certainly very important is the patient diversity. And we see patients with PAH across all racial, ethnic, gender barriers. And so it's not enough to lump every patient together. We really do need to look at specific groups of patients to see if they're differentially affected by this condition. And this is just one study actually specifically looking at a physiologic measurement of what we call RV to PA coupling. So a way to look at kind of how the right ventricle is dealing with the afterload on it, the load on that ventricle. And you can determine that, you can measure this sort of coupling index. And in fact, and this abstract found, in fact, that African-American patients with PAH have significantly lower degree of coupling, which is not good, compared to European Americans. Now, obviously that needs to be explored a lot further, but I think this is a sort of a 40,000 foot view saying that we really do need to look at different groups individually to see how they are affected. And that may in fact impact how we treat that patient population, what kind of testing, what kind of follow-up. So again, this is just a little snippet, but I think the concept of disparities and differences, racial differences, is an important one in our field of PAH as well. The next thing, also a sort of a patient-centered area, relates to parenteral therapy and why some patients refuse parenteral therapy. So just by background, we know that parenteral prostacyclin therapy, i.e. given as a continuous infusion, either subcutaneously or intravenously, is probably our most efficacious treatment. It's what we do in some of the sickest patients, and it's clearly been shown to have efficacy. But yet it's not infrequently that patients sometimes refuse that treatment. And this abstract was looking at why patients were refusing. And the answers included fear of its impact on their quality of life, challenges from having an indwelling catheter and a pump, like with showering and swimming, the fear of line infections, and the fear of ability to work, those kind of things. So, patients have had a lot of input in what could make their lives better if they're on these treatments, including pump size, water resistance, implantable pumps, which are being looked at. So I think that, again, there's a lot of developments in PAH, a lot of new oral medications, inhaled medications, but as long as we still have this continuous parenteral therapy, we need to continue to improve that and listen to patients. Getting into a specific treatment in this abstract for treprostinil, this was a real world type study. So looking at real world tolerability and management of adverse events in patients receiving the oral form of treprostinil. Treprostinil is a long-acting prostacyclin, which is actually available in all different formulations, IV, sub-Q, inhaled, and also oral. And so this registry, if you will, looked at the side effects, which are actually quite common in prostacyclins in general, like headache, diarrhea, other adverse events, and looked at the frequency of these events. And in fact, the adverse events were similar in frequency to what's seen in the larger study. So in real world, over half of patients get a headache, which gets better over time. Diarrhea, which is a big one, the prostacyclin, also over half the patients, but somewhat better over time. And then a variety of other symptoms and adverse events. So I do think it's important, and not just with this drug, but in general, to look at real world registries. You look at the data from pivotal trials, and that's important, but in many ways, that's not reflected in the real world once these drugs are on the market. So kudos to the various sponsors of these therapies that they look at real world registries. Another treatment is macitentan, and this abstract is one actually I was involved in, which is looking at the effects of macitentan, which is what we call an endothelin receptor antagonist. And we looked at this drug. This has been available on the market for a few years now, and we looked at it specifically on cardiac function. One of the important concepts of pulmonary hypertension treatment is that we really want to see that we're improving the right ventricular function and remodeling the right ventricle, if you will, on PH treatment. So even though we're affecting the pulmonary vessels, we're hopefully improving the function of the right ventricle. And this is a study where we looked at right ventricular function as assessed a number of different ways, in MR and even echo. And what we found, in fact, was that many different parameters, both on MR, magnetic resonance imaging, and on echo, improved with macitentan. And this was actually reassuring, not to get into the technical details of some of the RV measurements, but RV stroke volume which was our sort of primary endpoint from this so-called repair study, was significantly affected. And in this particular abstract from the CHEST meeting, we saw similar findings on the echo parameters. I think one of the concepts is that, MR is a tough study to get and hard to get repeatedly. It takes a while to do. Patients sometimes have a problem in the scanner. So it's nice to see in this abstract that echocardiography could give us some of the similar findings in response to macitentan with improvement in some of the RV parameters. Okay, so the next interesting thing is, and I think the theme you're getting from these abstracts is that, these are all approved drugs. We're not talking about, so far, new treatments. We're talking about available treatments that are already being used, but now being looked at sort of in different perspectives. And this particular abstract was something that we thought about for a while since this drug riociguat has been on the market. This is a guanylate cyclase stimulator. So it works through the nitric oxide pathway, similar to what we see with sildenafil and tadalafil, but in a little different way. It's what we call NO independent. So it can really bypass the endogenous NO production. And so there's some rationale for why patients who might not be doing as well as we'd like on a PDE5 inhibitor like sildenafil might do better when we switched to riociguat. So this was the so-called REPLACE study, which was an open label study where patients were either switched to riociguat or maintained on the PDE5 inhibitor. And what was looked at was absence of worsening with that switch and also signs of improvement. So improvement in functional class, improvement in some of the biomarkers like BNP with the switch, or if patients stayed on PDE5 inhibitor. Found, in fact, that 41% of patients who were switched to riociguat met that endpoint versus only 20% of patients who stayed on the PDE5 inhibitor. There were no deaths in the switched group versus 2 in the patients that stayed on the PDE5 inhibitor, and similar adverse events. So this is actually fairly interesting and provocative, showing that it did seem that in a significant number of patients, when they were switched from a PDE5 inhibitor to riociguat, they did improve and meet those treatment criteria. So again, not a big study, not a blinded study, but one that certainly suggests a potential way to manage some patients who are on PDE5 inhibitors and are not meeting treatment goals. So I think that's, to me, a pretty exciting finding. We then have an overall survival abstract in patients treated with parenteral prostacyclin. And this study looked at 145 patients retrospectively and looked at survival based on the diagnosis, idiopathic, connective tissue, or congenital. And very briefly, they found that patients, and this is sort of in the modern era of treatment, who were on IV therapy for idiopathic PAH had an excellent survival over 7.5 years, with 14% going on to lung transplant. Patients with congenital heart disease also had a pretty good survival at 6.8 years, 20% transplants. Unfortunately, connective tissue disease patients still didn't do that well, with a 3.7% average survival, and only 2% going on to lung transplant. So we still have this challenge in this particular subgroup of patients with connective tissue disease to really find a good or optimal treatment for those patients. There's maybe a number of reasons for why patients with connective tissue disease don't do as well. It could be based on the underlying pathology or some of the other complications they can get with connective tissue disease. But we still have room to really improve in how these patients do. There was then a study looking at another sort of approach to therapy, which is triple combination therapy using macitentan in this particular abstract. And the general concept is, in general, that we think that multiple drugs that work in different pathways will improve outcomes and improve how patients do. And that, in fact, is emerging in a number of different studies. This particular abstract looked at data from what we call the OPUS registry, which is a registry of patients who are treated in the real world with macitentan. And we looked at this particular subgroup of 400 patients who received triple therapy at one point. And in fact, we found that about 63% received triple therapy for at least a year, with about 50% for at least 2 years. And, some patients stop due to adverse events, but that's, a significant number of patients that are now in the real world with real world prescribers being treated with triple therapy for PAH. And I think, if we do this registry or study again in 4 to 5 years, we'd see even more. This is where I think the field is heading. And I think you'll see in these real world registries, those kind of practice patterns changing. Again, underscoring that the real world registry is really becoming very important. Finally, the field, and I'm involved in this field, is moving on rapidly. And although we have a number of great treatments and these treatments improve patients' lives in many different ways, we're really still attacking one of 3 pathways: nitric oxide, prostacyclin, or endothelin, with the same drugs. And so, there's room for improvement. There's room for, new mechanisms, new avenues, and then there's room for new formulations and new drugs within the approved classes of drugs. And so this is just one drug in development that was presented at CHEST. Again, every meeting there's a few more, and this is an inhaled form of vardenafil. Vardenafil is another PDE5 inhibitor. And this was an open-label phase 2A study looking at the change in pulmonary vascular resistance in 14 patients, and showed, in fact, that a dose of inhaled vardenafil given actually a dry powder inhaler formulation decreased the PVR by at least 10% after 5 minutes, and that lasts for up to an hour. So in addition, there were some improvements in oxygenation, and importantly, no change in the systemic blood pressure or heart rate. So I think an inhaled, a drug that can be given through an inhaler that can last a while, and in this case, it's vardenafil, really, I think, has a lot of hope for pushing the field forward. So clearly, this is early phase 2 study, so additional data is needed and additional studies. And again, as I mentioned, there's other treatments, not necessarily presented here at CHEST, but many other treatments that are being looked at in phase 2 and even some in early phase 3 studies. So, this was just one example. So very, very exciting time. So in closing, I think the CHEST 2020 meeting, although again, very unique, and it's the fact that it was all virtual, continues to move the ball forward when it comes to PAH. We know that, patient diversity exists. There is no typical PAH patient. You tend to want to look at each group individually, each diagnosis individually. That the real world registries looking at new treatment patterns and how they're evolving, I think is very informative to clinicians treating this, sort of going beyond the pivotal clinical trials. And again, new PAH trials are coming on and will continue to emerge as the field continues to grow. I think, again, just to emphasize that in the end, this is all about patient quality of life, improving the patient's lives in all ways that are important to these patients psychologically. These things are all really important, and we have to really keep that in mind as we're developing trials and protocols for this exciting, what I think is a very exciting time in pulmonary arterial hypertension. Thank you.